Hello and welcome to UKFitnessHub.com. My name's Travistarrant and in today's video we're going to be covering Tibialis Posterior Tendonitis. We're going to be going through what it is, the causes and how we can treat it to make it better. Let's get into the video. So to kick off this video, let's talk about the tibialis posterior and where it's located on the body to start off with. So firstly, the skeleton here is looking away from the camera. So we're looking at the back of the leg, and the tibialis posterior is a deep compartment muscle that has several origin points. The first one is on the fibula bone just here. We've then got another insertion point on the tibia bone. Again, we're looking at the back of the leg. And then we've got the interosseous membrane, which then goes between those 2 points. When we then look at where it goes down to, well, this is the inside here of an ankle. So it comes down the inside of the ankle, wraps around and underneath that medial malleolus, and then attaches at the bottom of the foot on the navicular bones, the 2nd, 3rd and 4th metatarsals, as well as all the cuneiform bones. The tibialis posterior muscle has 3 main roles and functions, and the first 2 are to assist in plantarflexion of the foot and inversion of the foot. So let's go through those really quickly. If I bring my knee up, me doing plantarflexion of the foot looks like this, pointing the foot down. I then can invert the foot by pointing the foot in towards the midline of my body, and the tibialis posterior plays a role in assisting those 2 movements. Of course, we can do both of them at the same time as well, plantarflexion and inversion. Of course, then we have the role where the tibialis posterior also supports the medial arch of the foot. So we spoke a little bit about how it wraps round and goes underneath the foot. Well, if I see someone that's got, let's say, a rupture of the tibialis posterior, they'll have one foot that looks like this and the other foot where the arch is completely collapsed. So all of a sudden that arch is not getting the support of the tibialis posterior because it's snapped, and therefore we see a big shift in what the feet look like side by side. So what is tibialis posterior tendonitis and what can we do about it? So firstly, tibialis posterior tendonitis can happen for a multitude of different reasons, and we'll go through that. But firstly, tendonitis, tendons attach muscles to bone, and itis means inflammation of. So we've got inflammation of the tendon that's coming down, wrapping around the inside of the ankle and then going down to the foot. So for example, let's take a runner, which would be the most typical client that I would see with tibialis posterior tendonitis. They could be a seasoned runner that runs a certain amount of mileage. If they then up that significantly overnight, that can cause tibialis posterior tendonitis. The same thing with a new runner, so somebody that doesn't run at all of a sudden they've done a bit too much too soon. Excessive loading and a jump in loading can cause tibialis posterior tendonitis. One common one that I see is people running on cambers. So for example, let's say, especially here in the UK, you're running on the inside of a road, you're outside of traffic. If I've got the ankle in a nice stable position, everything's going to be great in the shoe that I'm wearing. If however I'm on a camber, let's say for example my foot's more in this position, I'm then going to be compressing that tendon, and the same can actually happen the other way. So if I then overstretch the tendon as I'm running, that can cause irritation as well. Footwear is a big one, so I always ask runners, what shoes are you wearing? And often I'll be looking at the shoe to see, is it too flexible? Is there loads of give in the shoe? Or is the shoe really tight and again could compromise the tendon where we're compressing the tendon? Lastly, if those are issues, then what I'm looking to do is then test the strength of the tendon. Are they in the acute phase of injury? When they stand up, if they're standing up for long periods of time, is the individual getting lots of pain? Or is it they're running, let's say, 5 miles, and on the 6th mile it starts to hurt, but before that it's absolutely fine. Excessive or new amounts of downhill running can also be a cause of tibialis posterior tendonitis due to the shearing force and load placed on the tendon. Finally, there are two last things that can make tibialis posterior tendonitis more susceptible, specifically for runners. So let's say, for example, you're looking at my leg here. This is the natural position of my knee and leg. If I have a runner that is dipping into inward posture of the knee, watch what happens to the foot. So my foot's nice and stable here. The inside arch of my foot now is going to have more pressure by having to tolerate that knee coming in. Now, if I then place my hand on my glute, bring my knee in and push my knee out, it's my glute medius that's actually doing the abduction of the knees. So strengthening up the glute medius in a lot of people is actually something we do during their rehab programs. Finally, what's ankle stability like? So for some people, they'll be standing on one leg and they'll be completely still, and for others, they might be all over the place. So ankle stability and working on ankle stabilization is as important as making sure that glute medius is strong when we are running. So let's say, for example, someone's come into the clinic, they've got a very acute phase of this injury, they've got lots of pain. The first thing we have to do is what I call deload and reload. So firstly, we have to stop the activity that's causing us pain, otherwise we're just going to keep flaring up the symptoms. We can use things like topical gels, so ibuprofen gel, that type of thing. But things like ice, just putting on ice for 5 minutes, making sure that we do it morning and night. And of course, if there is a period of activity where we have to do, so for example, if you're at work for 8 hours a day and you can't get out of that, and then the foot starts hurting at work, halfway through your shift if you can, and then at the end, you might want to apply 5 minutes of ice just to bring down that inflammation and stop the area getting as angry. The first thing that I'll be looking to do simply with a client is to try and get them doing resisted inversion and plantar flexion in an isometric fashion. So the first thing that I would do is I'd get them sitting like this. I want them to point the foot down and then point the foot in towards their body. If they then at this point get pain, I immediately know I cannot do this exercise with them because it's going to start increasing their pain symptoms and cause a flare-up. If they're able to do that simple movement, what I can then do is place the hand on the inside of the foot, and I can start pushing into the inside of the foot. Again, if they get pain, we stop immediately, we do more rest and icing. But if they can do that, brilliant. So what we're looking again to do is down and in, and then once we're in that position, hand goes on the inside of my foot and I'm pushing into my hand, and I would do 2 sets of 15 seconds. Once that's good and we can do that and we've passed that test, next thing I do is I've got a band here. What I'm going to do is I'm going to point the foot in. I'm going to sit a little bit away. I've got this hooked around the bench here. Support my knee, and what I'm doing is I'm just again doing isometric contractions. We can start then going on to our last 2 exercises, which are firstly toe flexion. So I'm sat here on a chair, I've got my heel off of the towel and the rest of my foot's on the towel. I'm then going to claw my toes into the towel and bring it towards me. And we spoke about those insertion points, didn't we, earlier, where the tendon goes down, attaches onto the bottom of the foot. So if we can strengthen up the bottom of the foot with toe flexion, that can only be a good thing. So what I'm going to do is I'm going to start gripping my toes into the floor, and you'll notice the towel is moving towards me, and I'll do this for 2 sets of 15 repetitions. Something else we can then progress on to at the latter stages of recovery is heel raises, specifically just doing heel raises on both feet first. And then of course we can progress it to a single foot variation. So heel raises, we would start off just coming up, having our hands on something for support, and really trying to squeeze at the top of the motion and slowly come back down. You wouldn't be doing this off a ledge or a step. I'm not looking for you to stretch out the calf. Typically stretching of the calf will irritate this type of tendinitis. And once we get really good and we're confident, we can then start loading all of the weight of the body on 1 foot. And again, that would be 2 sets of 15 repetitions. When you're recovering from something like this type of tendinitis, what I do as a therapist is very much a vague plan, and then we look at how the body responds. So for example, let's say someone's passed all those exercises and then they go on to doing 2 sets of 15 repetitions on calf raises, and then they start to get a flare up. What I would then do is take that exercise out. I might then wait for that kind of flare up to go. I might then do 2 sets of 5 repetitions. If that still flares them up, we then do the exercises we was doing without flare up for longer, get a little bit more strength within the tendon, and then we go back to it at a later point. Or if they say, actually, 2 sets of 15 repetitions flared me up, but 2 sets of 5 was absolutely fine, we've deloaded them, and then we'll progress that over time and reload them up as well. And of course, all these exercises, if you do get a flare up, you've got your goals of 2 times 15 or 2 times 15 seconds or reps. You don't have to do that. You can progress up to that. That's the goal and target. But if you can't do that, it's not a problem. For those that are professional athletes, they find all of this very, very boring. So what I like to do is get some ankle stability work and some glute medius work in at the same time to give them something else to do as well and make the rehab a little bit more fun. So at least when they come back to running, not only are they going to be better with regards ankle stability and glute strength, they then won't be in pain as well. So whilst they're injured, they might as well work on ankle stability and also the strength of the glute medius. So let's go through glute medius exercises first. Unlike the previous exercises we just covered, we can do all of the 4 glute exercises that I'm going to show you 3 times per week. Just don't do them on consecutive days. I'm going to show you 3 glute medius exercises and 1 glute max exercise. And all you need is a mat, something comfortable for your head, and I would recommend getting a pack of looped resistance bands so you can start working up through the resistance bands in terms of their strength. The previous exercises we covered, one of the questions that I always get is how many times should I do this a week? And it does depend on where someone is at with their symptoms and the severity of which. So for some people, they might just do it 3 times a week and see how they get on. For others, it might be more every other day. So it does depend on your symptoms and where you're at in your recovery. These, however, you can do 3 times per week as soon as you get over that initial flare up that's causing you pain and you start to deload from the activity giving you pain. So firstly, I've got this resistance band around my ankles and I'm going to do hip abductions first. Now, I'm going to be laying on my side. I'm going to make sure the pillow here keeps my head nice and neutral. Legs are completely straight. I've got my hand here forwards to make sure that I don't cheat during the motion. And all I'm going to do is lock out my knees and bring my leg up and away from my body and back down. So coming up towards the ceiling. If you struggle to get that glute contraction, try and squeeze your glutes as hard as you can and keep them squeezed as you come up. Big pause at the top and slowly back down. Everything we're going to cover is 2 sets of 15 repetitions. Once you've done that one, you can do clamshells. You can do all of these back to back. Now you'll notice the band is just above my knees. Similar position, so I'm still laying on my side. However, this time I've got my feet on top of each other and it's my knee that comes away from my body and back in. So away from the body, keeping my feet on each other. Again, I don't want to be using my upper body to cheat. And once you've done 15 repetitions for 2 sets on both sides, then you can keep the band in the same position for glute bridge abductions. So for this one, bring your feet in nice and close as far as you can to your butt. You've got your feet just outside your hips. I'm going to bring my tailbone up off the floor first, then my lower back, and then my mid back. And now I'm in a glute bridge hold. And what you're going to do from here is knees come out as far as you can. Really pull on the band. You should be feeling your glutes. And from here, slightly in and back out. Slightly in and back out. Whilst trying to keep your hips nice and high. You shouldn't be feeling this in the lower back. And again, if you struggle for that glute contraction, think about squeezing the glutes and turning them on for your 2 sets of 15. When you come down, mid back down, lower back and tailbone. For your last exercise, which is hip extensions, you're going to put the band around your laces, come into a tabletop position, and from here I've got my shoulders directly above my wrists, I've got my toes in contact with the floor, and one foot is going to stay in contact with the floor and the other leg is going to kick back, big glute squeeze and slowly back down. Big squeeze of the glute, slowly back down. Make sure you don't arch your back, so we want to keep the back nice and flat, otherwise we might end up doing this. So always looking down, back completely stable and neutral, and you're going to do 2 times 15. For the stabilization exercises, those happen after we have recovered from the initial flare-up. So you can start putting these in at the first stages of your recovery, whereas these stabilization exercises I'm going to show you, start putting them in when you can start doing calf raises. Once my clients are at that end stage of rehab, I want them to continue all the glute medius and glute max stuff and put that into their programs if they're doing running or sports. And it's the same with these ankle stability exercises. If you're thinking, why don't we start doing these at the start of a rehab? Well, again, it's that load and reload principle that we was going through earlier. So a lot of the time, that tendonitis can only tolerate a little bit of exercise to begin with. So we start putting in loads of ankle stability stuff. It just puts too much load through that tendon. Whereas actually at the end stages of rehab, when that tendon's built up some strength, the inflammation's gone down, we want to make sure the ankle is as strong as possible. One, to protect the ankle from further injuries and to stop the tendonitis from coming back. So one of the things that I'll do firstly is simply get somebody on one foot. They'll always do this on both feet, even if they just have the tendonitis in one. And they'll simply try to maintain the arch of the foot whilst just simply stabilizing and looking at a point on the wall. So I want to make sure they're not collapsing in, they're keeping the knee nice and aligned with the foot. And again, their arch is maintaining that integrity during the exercise. Once they get good at that and they've got up to 30 seconds or 45 seconds where they can just hold on one leg, what I'll then do is I'll start to get them incorporating some throw and catch. This way, there's a little bit more proprioception, and something like 2 sets of 15 is always a good one on that one. And then what we can do is we can start doing dynamic movements. So for example, balancing on one leg, coming straight back into a reverse lunge, and coming back into balancing on one leg. So dynamic, simple movements, again, 2 times 15. Once they get good at all of those, we start to introduce the proprioception pads. They do all of those 3 exercises, but this time they're doing it on a pad, which for them is going to make it substantially harder. So the pad, unlike the floor, is going to make the ankle do this. It makes the ankle work really hard. Then they start to do that single leg stabilization, then start to do throw and catch, and then they would do exactly the same, doing their high knee into their reverse lunge, but just on the proprioception pad. I'm now going to answer 2 commonly asked questions that I get with regards to this specific rehab, and then we're going to recap some of the things we've gone over and some of the general advice before ending this video. So one of the questions is, one thing I've told you not to do is stretch out the calf and stretch out the soleus. And that's because typically it will inflame and it will make the area worse. So what I do to keep the calf and specifically the soleus muscles nice and loose, especially if somebody's in that acute phase and they start loading their good leg where that all gets really tight to compensate, is I'll generally do that via sports massage. So I'll manually treat the area myself when they're coming in for their rehabs to make sure nothing tightens up, such as other structures around the lower leg. I typically do not get clients to do any abrasive stretching because it tends to make it worse. Only when they've got to the end stage of rehab do we then start implementing stretching. And of course, we want to make sure we don't get a flare up when we do that. But it's sports massage that I do manually with clients to make sure the area is nice and loose and there's no muscular tightening of surrounding muscles. The other question I get specifically, again, runners, Should I use a custom orthotic? If somebody's got quite a low arch, they might want to come in and get a custom orthotic. For 95% of clients, it just isn't necessary. And to be honest with you, they can get insoles from things like Amazon, and they might as well try those out before spending hundreds and hundreds of pounds on custom orthotics. Only when it is a high level athlete would I refer someone on for a discussion about something like custom orthotics. Now let's recap. So when you've got this condition, if it's really angry, you simply don't do anything. You deload from what is causing you pain and dysfunction. You find out what the root cause is that has developed your tendinitis issue. Then from there, start calming down the area with ice, which you can do 2 to 3 times a day, again 5 minutes. You can do hot and cold as well if you end on cold. So for example, hot for 5 minutes, cold, hot, cold, again 5, 5, 5, 5, making 20 minutes. In my experience, it doesn't make too much of a difference, but some people quite like it. If you're then in a stage where the area is calming down, we can start to do those simple isometric exercises. We could then progress onto the toe curls and also the calf raises. At the beginning stage, we can always implement all of the glute work that we covered, and it's only at the end stage when I start implementing some of those ankle stabilization exercises. And that concludes the end of the video on posterior tibial tendonitis. I'll put all of what I've used in this video as links in the description should you need to buy any of the equipment I've used. Otherwise, thank you very much for watching. You've been watching UK Fitness Hub. I've been Travistarrant. Be sure to subscribe for more free and educational content. I'll see you in the next one.